We have our next speaker, and Dr. Maritza Perez. She is a certified dermatologist from the American Board of Dermatology and also College of Mohs Micrographic Surgery. She is the director of cosmetic dermatology at Mount Sinai West Medical Center in New York, and is a clinical professor of dermatology at Mount Sinai Icahn School of Medicine. She is visiting professor of dermatology at UConn Health University of Connecticut School of Medicine. And she also has a private practice, Advanced Aesthetics, and is located in New Canaan, Connecticut. She's an active member and has published numerous research and articles and chapters, and also involved with numerous organizations. She is a graduate of the University of Puerto Rico School of Medicine, where she completed her residency in dermatology. And then she completed postdoctoral training in immunodermatology at Columbia College of Physicians and Surgeons in New York, and dermatologic surgery, including Mohs micrographic and laser surgery, and cosmetic dermatologic surgery at NYU. She's had an extensive and continues to have an extensive media presence, both on television and other media outlets. And so we are just excited to have her today and her expertise as she talks to us about aging across ethnic variation. So thank you so much for being here today.
Well, good afternoon, Pam, and thank you very much for inviting me. Let me see how challenging is this share my screen for today. Okay, so I'm going to be presenting for you today something that is kind of totally new, and it's been actually all this work was done funded by Procter & Gamble. It was done by the scientists in Procter & Gamble, and in collaboration with Dr. Kimball in Harvard, and now she is in Deaconess. And in this new information that it's going to try to reveal how different ethnicities age equally or differently, and is also going to try to present how lifestyles actually influence the aging process. And in the process of presenting this, theoretically, I will supply some ingredients that then can influence the appearance or alter the appearance of the aging process in all ethnic groups. And upon completion of this session, the participants will improve their competence and performance in understanding the molecular mechanism which contribute to the skin aging, both intrinsic and extrinsic across different ages, body size, and ethnicities. And it correlates with the histologic findings of extrinsic and intrinsic aging, correlating it with clinical appearance and molecular signs of aging, and ultimately demonstrate how lifestyles affect the aging process at the molecular level. So this study was started in 2003 and has continued all the way to 2018. And the objective was to fundamentally understand the molecular mechanism which contributes to the skin aging, both intrinsic, which means in sun-protected areas, and extrinsic, which means sun-exposed areas, and done in different group ages, body sites, and ethnicity. And if you look in here, you can see that there was a multiple decades of patients were selected in their 20s, 30s, 40s, 50s, 60s, and 70s. Biopsies were obtained from different sites, being the sites exposed and non-exposed areas, exposed face and arms, and non-exposed buttocks. And multiple ethnicities, patients of Caucasian origin, African American origin, Chinese and Hispanics were selected. And then the studies were done in multiple measures. It was the appearance of the skin structure, the biology of the DNA, genomics, proteomics, and some hormones. So this is the presentation of the study that has taken over a decade and a half. And this is the totality. There's Caucasians from 20 to 24, African descent, Hispanic and Chinese, 40 to 44, and then 60 to 64. And you're going to see that the lower numbers are in the Hispanic descent and Chinese descent. The higher numbers are in the Caucasian and African Americans. And how you're going to ask me, how do we know exactly the origin of these patients? So there's some genotyping analysis that was done with 23andMe, and these patients were analyzed, their genetic background was analyzed, and find out to be considered Caucasians, they have to have a high percentage of European origin, Northern European or British origin, as you can see in this slide. To select the patients that were of African American origin, the patients have to have a significant percentage of their genome represented by origin of African, West African, and less of Northern European. So when the biopsies were done, and remember the biopsies were done in exposed areas of the face and arms and also in covered areas of the buttocks. And here are all the Caucasian patients in the left, the African Americans in the middle, the Hispanics and the Chinese, and is across the different decades. You can see the first thing is that if you look close to sun exposed areas, being that the face and the arm, you're going to see that in the Caucasian patients, you start seeing elastotic changes in the fourth decade, but it's definitively very remarkably diagnosed in the exposed areas in the seventh decade. In contrast, you're going to see that you do not see any elastotic changes in any of the decades of African American descendant patients. And you're going to see elastotic changes in exposed areas of both Hispanic and Chinese. So therefore, there is a marker of photoaging that is documented histologically by elastosis, that is documented in the early decades for the Caucasians, in the middle, in the later decades for the Hispanic and Chinese, and not documented in the African Americans. So here now we're evaluating the histologic findings as per the different ethnicities at different decades. And you're going to see that in the 20s, there's no evidence of elastotic changes in any of the exposed areas. However, in the fourth decade, you're going to start seeing that in the Caucasian exposed areas of the face, you're starting documenting elastotic changes. And then in the 60s, you're going to document the elastotic changes in both the Chinese and the Hispanics, and definitively in the Caucasians, but not in the African American. So what is important, the evidence of, or the finding of elastotic changes in the dermis, and you can see from the physical appearance in photograph, the patient that has the most elastosis is the patient that is going to look the most aged. So elastotic changes correlate with the aging appearance of the skin. You see that this patient is 54 and looks more older than 54. This patient being 44 without elastotic changes does not have the evidence of aging. And this 70-year-old has elastotic changes and has more aging features of aging in the facial skin. And you see this 42-year-old African-American, no elastotic changes, no evidence of aging. So when you compare at least two of the ethnicities, the African-American and the Caucasians, you're seeing by appearance, the facial appearance, that the features that you see in the 64-year-old Caucasian are equivalent to, excuse me, these features that you see in the 64-year-old African American is features that you don't see, you see kind of in a decade earlier in a Caucasian patient. So meaning by that is the Caucasian patient at the same age, he looks 10 years older than the African American patient. And what about the thickness of the epidermis? It's been demonstrated in this study by histology that the thickness of the epidermis starts decreasing after the 5th decade in Caucasians and after the 4th decade in Hispanics and the 6th decade in Chinese. In contrast, there is no diminution of the epidermal thickness in African Americans at any of the evaluated decades. So what about the gene expression? Because now we have analyzed the component of the histology. Now we're going to evaluate what is the genomic, how this is translated into the genome. And this is kind of just a representation of gene expression profiles. Anything that you see in red means increased gene expression. Anything that you see in blue indicates this decreased gene expression. And you can see here all the different ethnicities that are represented in the lower part. And you can see that this is in the 4th decade and this is in the 6th decade. And you can see that, and as you're going to see also in the next slide, that in the epidermis, there is a lot of red that goes into blue in the epidermis, and the contrary is happening in the dermis. So there is kind of a reversed expression of genes. And how do we get this gene expression? So remember that you take the mRNA and you put the mRNA to code for proteins, and then you find out what those proteins do, and then you can qualify what components of the functionality of the cell are being involved, either positively or negatively. And so this is the slide that kind of tells us that when we evaluate all the ethnicities and all the decades in the epidermis, you're going to see that gene expression, the heat map depiction of facial gene expression demonstrate that the majority, approximately 75% of the genes are increased in the epidermis, and in contrast, we see that the majority, approximately 75% of the dermal genes are decreased in expression, meaning by that turning from red to blue, because red is increased expression and blue is decreased expression. So at this point, I'm going to share with you in different proteins and pathways that were evaluated both in exposed areas and in non-exposed areas at the different decades. And we're going to evaluate one gene per each one of the functionality that is being seen to be altered at the different decades. For example, when it was evaluated the decades of the 20, the first thing that was noticed that was altered in the expression was the natural antioxidancy. So we started showing evidence of the aging process early in our 20s, and the first thing that goes kind of dysfunctional is the natural antioxidancy. When we go into the 30s, in the decades of the 30s, we see that there starts the cell energy, function of cell energy are being altered, start to be altered in that decade. In the 40s, cellular senescence starts showing, have an impact into the functionality of cell senescence. The skin barrier starts to dysfunction in the 50s, and then at the 60s, now when we're getting more into menopause, all the processes of the external matrix are altered, and I will go over each one of this. So the gene that was utilized to evaluate the natural skin antioxidants in the decades of the 20s was the GCLM gene, or gamma glutamyl cysteine synthetase. That is one of the pathways that ultimately leads to natural skin antioxidants. It was manifested, it was found out, as you can see here, that the expression of the gene starts decreasing in the 20th decade and continues to decrease along all the decades in all the participants of the study. So I told you that in the third decade, we start seeing this functionality of the energy pathway. We all know that the mitochondria is kind of the battery of energy for our cells. And in the mitochondria, there is the NADP, NADPH pathway that it's actually accumulating energy particles, energy molecules, and an oxidation, the oxidation phosphorylation pathway. This function started to be altered in the third decade. So giving you an idea of how we can intervene in each one of these decades by supplying the ingredient that is being dysfunctional in specific decades. What about cellular senescence? The cellular senescence is related to how the cell functionality lasts during the existence of the cell. And it relates to tissue dysfunction, is related to certain disorders. So when we see here in the arm, which is in red, and in the bud, which is the non-sun exposed area, when we see split the epidermis versus the dermis, we can see that in the not sun exposed area, the senescence, cellular senescence, is maintained uniform. However, the cell senescence increases, so the dysfunction of the maintenance of functionality of the cell increases as in the exposed area as decades pass. And it also happens, both happens in the epidermis and the dermis. But more the discrepancy between the sun exposed and non-sun exposed is more evident in the epidermis. So cellular senescence and ultraviolet exposure, is there any relationship in the different, at least in two of the different ethnicities? Let's take first the African Americans to the left and the Caucasians to the right, and then we're going to divide between the epidermis and the dermis and the full thickness skin. You're going to see that in the face and arm, which are sun exposed, and buttocks, which is non-sun exposed, the senescence in the African American patients is kind of uniform. In the epidermis, in the dermis, there is a slight difference, but not significant. In contrast, you can see that in the Caucasian population, upon sun exposure, meaning like face and arms versus buttock, you can see that there is a significant increase in the senescence, both in the epidermis, more marked than in the dermis, and the sun-protected areas do not show that contrast or difference in cellular senescence. Meaning by this, that ultraviolet exposure in the Caucasian population has an impact into the cellular senescence, making it more prominent, less than what it's in the African American population. So what about the epidermal moisture barrier? The epidermal moisture barrier, or the barrier skin, the barrier skin function, was measured by the lamellar body formation gene called gene. And if you test for this gene, and the product is the barrier products that sit in between the epidermal cells to maintain the integrity of the skin, you can see that in the arm, which is the exposed area versus the buttock, there is a decrease in both exposed and non-exposed area as decades pass. So the epidermal, the barrier function diminishes with the aging process without being affected directly by the exposure to the sun. What about in the 60s? As I told you, we now are in the 60s. There is now menopause is evident. There is the absence of estrogen effect onto the skin. And so there is a complexity of dysfunctions happening in the skin. So if you take the Eugene genes in patients in their 70s, you can see that the dysfunction of these Eugene genes is going to be 6.8 times faster after menopause than before menopause. So indicating that everything really, all the processes of the external matrix are totally affected once the sixth decade, once the patients get into the 6 decades and get into menopause. So let's try to find out what are the genes that are affected mainly. If we try to qualified which are the genes that are kind of affected the most, and these genes are here to your left, you can see there most of the genes are that are affected both in exposed areas as well as in non-exposed areas. The genes that are affected and are affected more by sun exposure, meaning by that this face and arms more than buttocks, that is the protected area, are genes that regulate DNA function. So histone methylation, regulation of the chromatin organization, transcription factor activities, transcription of cofactor activities, histone modification, chromatin organization. So the dysfunction of the genes that is impacted by sun exposure are the genes that function in a genomic, in the DNA functionality and translation into proteins that lead the cell to be more functional. So these cells become more dysfunctional as we mature and is accelerated by sun exposure. What about autophagy? That is the function of, when a cell stops being functional, it's kind of the recycling system. Autophagy is the cell and all the organelles get kind of destroyed and they get recycled to be used by other cells that are going to be developing or growing in the future. So it's kind of the recycling mechanism of cellular function. There are approximately 122 autophagy genes. And when we evaluate those genes at the different decades, as you see here, you're going to find that UV exposure actually affects autophagy genes. And let's go to the next slide to see it better. You can see it in here that in the face, there is more decrease of the autophagy genes than in the buttocks, which is sun protected. So if we want to see what lifestyle factors can affect the autophagy genes, we can evaluate, or we evaluated in this study, sun protection, moisture, usage of moisture, aerobic exercise, and smoking. So those were the lifestyle factors evaluated in these different patients at different decades, and in sun exposed or non-sun exposed areas. So in here you can see that if the patient used sun protection, meaning that the blue, there is less dysfunction or less decrease of the autophagy genes than if the patient does not use sun protection, meaning by the pink. So if the patient does not use sun protection, there's going to be more destruction of the autophagy genes. If the patient utilizes moisture on the skin frequently, you're going to see that the autophagy genes are maintained over decades better than the patient does not use moisture on the skin on a frequent basis. So the autophagy genes can be affected both by use of sun protection and by use of moisture on the skin. What about the activity of the patient? You know, if the patient leads a life of aerobic exercise frequently in blue, or if the patient does not utilize frequent exercise in the pink. And you can see here in the pink, the autophagy genes are going to decrease significantly in patients that do not follow a healthy lifestyle of aerobic exercise in comparison, in contrast with the patients that actually do it regularly. And ultimately, the ultimate lifestyle factor that was evaluated was smoking. So the smokers, the non-smokers are in blue and the smokers are in pink. And so the non-smokers maintain their autophagy genes across the decades much better than the patients that smoke, that decrease the autophagy genes shown here in pink. So in summary of this slide, you can see that the autophagy genes are really affected by lifestyle factors. So we can intervene with our lifestyle factors, how our skin functionality is maintained. So I hope that in the time that I have allotted for this presentation, you can come to the conclusion that we observe similar trends, but absolute different, subtle difference in skin changes with age across 4 studied ethnicity, not ultimately giving a total outcome. Is just warranting us further investigation is necessary in the future. I have presented in the transcriptomic analysis shown significant changes both in the epidermis and the dermis gene expression across multiple pathways from the earliest age transition study that was in the decades of the 20s. Remember that in the 20s, the first dysfunctionality that is seen is the antioxidant function. In the 30s is the energy function. In the 40s is the senescence, in the 50s is the barrier, and in the 60s is all the matrix functions, including the rapid dysfunction of genes that are under the influence of estrogen that is now absent. It was demonstrated in this presentation that UV exposure strongly affects the skin biology. It influences changes in gene expression, as we show by the sun exposure in the effect on senescence genes and the effect of autography genes. And also in transcriptional regulations, we saw that many of the genes that regulate the transcription process are affected by the sun exposure across decades and across different ethnicities. So it indicates that is a good sun protection habit really should be maintained across all ages and ethnicities. And this is kind of the references that that has been published and presented at difference. There's one that presented the original paper in the Caucasians, and subsequent publications are still in the pipeline because this is a very extensive and convoluted studies to bring to reality. And thank you very much for your attention this afternoon.
Excellent. I tell you, you should see the chat. It's there. It's just lighting up. Wow, what an extensive review. It takes me back to basic science. Um, Justin, I do believe we have some questions. I'll let you ask those.
Excellent. Thank you, Dr. Perez. Really do appreciate your talk. A few questions that have come up in the chat is, should we be concerned about the harms from nanoparticles for facial and lip sunscreens, which are kind of, at this point, I mean, they're really recommended for not only daily use, but multiple times during a day. Do you have any concerns about those uses?
I really have not found out that the literature in the nanoparticles is very convincing. And until I find out that there is real harm, I still value a patient's improvement or the patient's maintenance of their functionality of their skin based on the evidence that is very well documented in the science of sun exposure. If you expose your skin to the sun, you get, time-eating dimers, and the time-eating dimers have been documented very effectively and efficiently that they interfere with P53 mutations, and those interfere ultimately induce the formation of skin cancers. That is very well documented evidence. There is evidence in what I just presented that sun exposure interferes with cellular senescence, with autography. It impedes, that lifestyles have an impact into our genome and to the functionality of our cells. I will weigh those that knowledge that is documented scientifically very strongly against a potential for some nanoparticle that I really don't know that really is going anywhere. And if it's for the maintenance of the patient's or the delayed of the aging process, or for the delayed of appearance of skin cancer, I will militate and promote the patient usage of sun protection. That not necessarily has to be only sun protection topical utilization. It can be hats, it can be, clothing, sunglasses, not necessarily. It's just the nanoparticles in organic sunblocks is just one component.
Thank you so much for that thorough explanation. Another few questions that we have is, what do you think of the role, what do you think is the role of sunscreen in people of African descent? And the follow-up to that question is, does exogenous estrogen in the setting of hormone replacement therapy reduce menopause-related effects on skin aging?
Okay, so let's take first the first one, because I was actually, and I am a part of the task force for skin cancer and skin of color. And obviously this has been a very hot topic. The utilization, I know that there's those that think that the utilization of sun protection in skin of color should not be promoted because there is less evidence that there is association of melanoma. The melanoma that is seen in patients with skin of color, be that, the African Americans is the acrolentigenous melanoma, and the Latinos is more of the nodular and superficial spreading. Apparently, not apparently, there is not a direct correlation of sun as the induction of the malignancy. And we know that in skin cancers, squamous cell carcinomas is seen in African Americans in more covered areas, not sun exposed, and it's not the genetic association that I just told you before is not very evident in the skin of color of African descendants as we can see it in the Caucasian population. So there is a trend to try to differentiate the skin of color sun protection sunblock use versus the Caucasians. And I still feel, and it's my opinion, that if I start telling my African-American patients and my darker Hispanic patients that it's not important for them to use sunblock because it's not demonstrated that they are, the sun exposure is related to the development of melanomas or squamous cell carcinomas, but yes, for the basal cells, I will be doing a disfavor because I know that, as I just presented, there's other functionalities in the skin that are being affected. So it's not only the melanomas and the squamous cell carcinomas, because basal cells really have been demonstrated to be related to sun exposures, even in the skin of color population. But this is function of the antioxidant, the dysfunction of the cellular senescence, the dysfunction of the skin barrier. So I will be doing a disfavor for the other functions of the skin that are being affected by sun exposure. So I will prefer for my skin of color patients still to use sun protection, at least in my opinion, until there is a total demonstration that there is not an impact. And then can you repeat the second question?
Absolutely, and thank you for that thorough explanation. Does exogenous estrogen in the setting of hormone replacement therapy reduce menopause-related effects on skin aging?
Actually, these studies are very, very old, and it was they were done by Tanya Phillips, and it has demonstrated that estrogen has an impact, replacement of estrogen has an impact into the maintenance of the matrix function, the cellular matrix that encompass, the fibroblast producing collagen, that is the network that then get together and create the ground substance with, with all the hyaluronic acids. And so maintaining that functionality of the matrix is being impacted by by replacing estrogen. However, we know that estrogen replacement also can be associated as you age, as being associated with development of breast cancer. So it is another function. It's like, do you want your patient to have a great skin and good matrix, but develop breast cancer? So in that, in that cost effectiveness, risk versus benefit value, I will militate against estrogen replacement, because if the patient is going to develop breast cancer, I prefer to have dysfunction of the skin than to have breast cancer. However, there are products, at least there's one product that is in the market, and I have no intention of mentioning, but is there one product in the market that is a synthetic a ingredient that is from a plant source, and that acts like there's estrogen receptors in the epidermal cells, and it acts associating with those estrogen receptors, but is cleared in the epidermis immediately, does not go systemic, and has demonstrated, at least in one study, to be effective in the maintenance of the youthful skin in patients post-menopause.
Excellent. Thank you. There's another question that came up that relates to the studies that you presented. And did they show any difference in people of African descent of different shades? And does solar elastosis occur in African Americans with lighter skin versus someone with darker skin?
That is one of this. That's a very good question, but you remember that I told you at the first, my first conclusion is that these are exciting results, but however, we don't have all the answers. And that's one of the answers that we don't have. The African-American patient, participants that were included by their genome, by their purity of African descendants, not by the tone of their skin. So therefore, it will be a great study to find out, and it happens also in the Hispanic population, that we're just a mixture of everything. It will be what happens to the lighter tones versus the darker tones. And you can speculate, the only thing that you can do until the studies are done, that there might be more elastosis in the lighter skin than in the darker skin tones.
Excellent. Well, thank you so much. Another question has come up, and my naivete is showing here, and I'm going to try to pronounce this. The question is, what is an IgG gene? It's EIGE.
UG gene, the UG gene. Okay, the UG gene is a marker of kind of moisture. Okay, so it's you remember that I told you about the lamellar bodies when we in the epidermis, when the epidermis is differentiating at the level of the granular layer, then the cells produce these lamellar bodies that go into the outside, and that's where the ceramides and the sphingolipids and all those are together, and those are the ones that kind of glue the epidermal cells that now have no nuclei, meaning by that the corneocytes. So the UG gene is a function of the production of lamellar bodies and the barriers. So it measures the skin barrier functionality.
Excellent. Thank you so much for that clarification. That appears to be all the questions that we have from the chat as of right now.
All right, I had a couple of questions, and it may have piggybacked onto response that you've already given, but that is with regards to skin shades of African Americans within the study. Did they document the Fitzpatrick skin tone on these patients?
No. If you notice, and we can go back to I think it was the third or the fourth, you can notice that all the African American participants were kind of the same tone, because what was the primary factor was the purity of African descendants. So see, if you're going to try to distinguish one population versus the other, the purity from, of their genetic background as measured by 23andMe was what was considered the limiting factor. So all the African American patients of descendants were in the 80 percentile, almost 100 percentile African and West African, and the color was in the darker shade. It will be for the future to now expand it to lighter versus darker. But then when you go lighter versus darker, you're going to find out that there's less purity in the percentage of African descendancy.
Very true. And then also with the study showing there's no diminution in the epidermal thickness, no major or just less amount of elastosis in the African American or Africans, and how to come across with skin or sunscreen application. And maybe we're going to, as I'm having to, because it's a struggle. That, they feel that they're not going to get skin cancer, and this is not going to affect them, but it will be an effect in their pigmentation, in their development of dermatosis papulosa nigra. And so those things get their attention.
Exactly.
The Morgan Freeman look.
Yeah. Well, as I say, it's like if I cannot convince my African American patients and my darker skin toned Hispanics to use sunblock because it does not make them prone to skin cancer, or it does not affect their development of melanoma or squamous cell carcinoma, at least I can convince them that in the process of functionality of the skin, your skin is manifesting senescence, a little bit of senescence, not as marked as the Caucasians, but it's also manifesting decrease in autography, which means that there is dysfunction of the skin that is being manifested or affected by sun exposure. And if I can then convince them also that, they're going to get darker skin, and that darker skin is going to be part of the aging process that is manifested in the skin, then if we can allow them to use sunblock so that they could prevent that, that will be at least a convincing argument.
Got it. To fulfill the full CME time amount, we have to go to at least 230
Uh-huh.
So any other things that you would like to talk to us about, or within the same realm, that would be helpful for our attendees who are not just only our medical health professions, but we have students as well as estheticians and cosmetologists
Okay.
on as well.
Actually, that's part of the, and thank you for allowing me to kind of expand a little more, in the sense that, I personally treat the patients in different decades differently. And this study gives me the opportunity of kind of doing an intervention kind of roadmap. So the patients that are 20 tell me that, I don't have to care about that because, my skin is fine. I tell, well, you're not producing antioxidants. So maybe a little vitamin C will be good. And we know that vitamin C gets degraded when there's sun exposure. So a little sunblock also can help you. But when we go to let's talk about the energy pathway, the NADP and ADPH. Niacinamide is very important. You know that niacinamide has been demonstrated to be effective in the skin for the blocking the transfer of melanosomes to of the melanosomes from melanocytes to keratinocytes, and it also is important in the function of the skin, increasing the filaggrin and the other epidermal proteins. And it's been demonstrated that niacinamide orally can be helpful for sun protection. So it's one of my interventions that I do in all my patients, including myself. I take 500 milligrams of niacinamide twice a day, every day, because I think that it's a good tool without being compromising anything in my health. And not niacin, is niacinamide. So, and then I use niacinamide as one of the ingredients for not only maintaining the youth look, but also to improve skin pigmentation. And, then we go to the barrier, as I was saying before. So, that then in the 5th decade, the barrier starts dysfunctioning. So let's start trying to repair and help the barrier before it gets dysfunctional. Because once it's dysfunctional, it's very difficult to get it back. So let's start using products with ceramides that actually really work. And it works not only in normal skin, it works also in sick skin, in dysfunctional skin, in the atopic dermatitis, in the cirrhotic elderly skin. So those are things that you can intervene. With little intervention, you get a lot of outcome. And as well, as we discussed before, is if you want to replace the estrogen, the absence of estrogen in the skin, there are products in the market, at least one, that you can do it in a safely fashion, at least demonstrated in one study, in which you can do an artificial estrogen-like molecule that is a phytoproduct. It comes from plant, and it gets totally degraded in the epidermis. It's only functional in the epidermis, doesn't have any systemic effect, and can be even used by patients of people that have had history of breast cancer. So the idea of being able to intervene in the aging process, it's important to me. And I do it on a regular basis with patients and in a regular basis with me.
Excellent. In your talk with your patients about sunscreens, what are your recommendations?
Well, and I don't want to sound too controversial, because I really not trying to be controversial, but I believe in inorganic products. I don't like chemicals. I'm actually allergic. I get photoallergy when I use chemical sunscreens. So I personally know that I cannot use them. So I value that in myself and in my patients. I don't want to be responsible for an allergic reaction. So I use inorganics. I use titanium dioxide and zinc oxide. And until we find out that the nanoparticles have any importance in disease state, I will militate to still use the nano particles of inorganic ingredients, titanium dioxide and zinc oxide. But in addition, I think that is very important for specifically the skin of color patients. You know that skin types 4 and 5 can develop hyperpigmentation upon exposure to visible light, and there's a pathway that has been identified for that. And the only ingredient that really works for that visible light induction of pigmentation that is manifested as either melasma or hyperpigmentation is iron oxide. And is iron oxide in high concentrations, not just a little iron oxide. So that's one ingredient that I also tell my patients to use. So the higher concentration iron oxide in the management of hyperpigmentation is very important for my skin of color patients.
Very good. And that provides a little bit of a tint.
Yes, and that is another one of the virtues, because that's the same ingredient that is used for foundation. So instead of needing to use foundation, I use my sunscreen or my sunblock as my foundation. And programs have demonstrated in her studies that the concentration of the iron oxide is important for effective protection against the visible light induced hyperpigmentation. So you have to be in the ranges of 3% or more.
Excellent. Just a couple more minutes. Do you also include the role of sunscreen protective clothing wear?
All the time. At least myself, you know, knowing that I'm allergic to some of the chemicals, and when I don't bring my own sunblock, I have to use the sunscreen that is available with whomever I am, and I can develop allergic reactions. I always carry my shirt. My sun protection shirt is long sleeves, and I always carry my hat. I am known for utilizing hats. I have all collections of hats because I have melasma, and every time that I get sun exposure, so it gets worse. And so I manage not only with the sun protection of the sunblock, but also physical and barrier.
There is one question that says here, since iron oxide is typically an inactive ingredient, the concentration is often not reported. Any suggestions on how to find it?
Okay, so that is a very good question. And the products that are available that contain iron oxide as, you know, as a real ingredient, not just as an afterthought. And I have no interest in the products at all, no financial interest. It's just that I know. Dermablend came out with a series of sunscreen, sun protection, that has different tones. It's like 30 or 40 tones, and it's available. And the higher the tone, the higher the concentration of the iron oxide. And that is kind of available in the market. If you look at the at some other products, like Aveeno has 3 different shades, and the darker shade has more than 3% of the iron oxide. But if it's not really kind of a valuable ingredient, it's kind of an afterthought, you're not going to see the percentage stated.
But those products that say on them sheer tint, they have some form of it. I've seen that.
Yeah, but
some of those.
Yeah, those are less than 1%, and it's not really.
Okay. Very good. All right. I'm hearing there is one question. Some BB creams, makeup have iron oxide?
Actually, yes, there is, and I don't know that it's still existent, because I was recommending it for my patients, and one of my patients told me they don't make it anymore. There's a BB cream that was a product, Epiclair of La Roche-Posay, and I don't have any interest. It's just that one has titanium dioxide, and it also contains iron oxide, but it does not report the percentage, and it's a BB cream. But the problem with the BB creams is because they don't report the percentage, you don't know if you have enough. of the iron oxide. So I will go to the ones that I will tell my patients that have hyperpigmentation like me to use the products that have the known percentage of iron oxide.
Okay, very good. Any further questions?
I just want to reiterate that, you know, as I have given this talk to my residents at UConn, is and in the last slide is very important. Our lifestyle decisions have an impact into our aging process, not only the internal aging, but the external aging. So what we can demonstrate in the autophagy genes is, you know, just one gene dysfunction that is affected by our lifestyles. But there might be a lot of other genes that are influenced, the dysfunctionality of which is influenced by our lifestyle. So lifestyles do have an impact. At least there's evidence that does have an impact into the aging process and the functionality of our body.
Excellent. I tell you, I know you're a busy person, and we appreciate you being able to be here, stopping by virtually in Oklahoma City to be with us today. And we'll have to have you back to talk about your surgical expertise as well, and issues within skin of color as it relates to skin cancer. We will have you tomorrow. For those of you who are not part of our Oklahoma State Dermatology Society meeting, we're having an annual meeting tomorrow virtually, and Dr. Perez is staying with us to talk about skin cancer in Hispanics in the US. Mm-hmm. And so that is another area that we need to hear about. And so thank you so much, and we look forward to seeing you again.
And I think that I will be reunited with you at 3 o'clock for our...
Yes, thank you.
Yes.
We will see you there. Hope to be a part of that panel discussion. Thank you so much.